Our shout out this week is to the listeners in Ghana, specifically the Greater Accra region. Thank you very much. We appreciate it.
Hi everyone, welcome back to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question you don't know the answer to, we feel you will be able to fall back on some principles to formulate a decent answer and to reason your way out of the trouble.
Welcome to another episode of First Principles of Medicine. Today we've got Brosca going through vertigo, and we've got a special guest as well. Alex, would you like to introduce yourself?
Cool. My name's Alex Madry. I go to University of Notre Dame, Fremantle.
Yeah.
I'm in my final year as well. Yeah, I'm just happy to be here.
And we've got JT, of course, just
Hi.
bringing up a relevant detail. And you've got me, Jason. So, Brosca, would you like to take it away with the first principles of vertigo?
Yeah, of course. So I think we should start with like the anatomy of the things involved in balance, and therefore like the things that can cause you to feel dizzy. And then from there, we'll talk about vertigo more specifically. So does anyone know what parts of the body are involved in balance?
Your cerebellum.
Ooh, the cerebellum. Let's just call it the brain.
Okay, I like it.
Nice and simple, right? Nice solid
That's
organ,
fine.
hey?
Yep. Now let's go a bit more peripheral.
The ears.
The ears, very good.
Are we going that broad? The ears?
Yeah, the ears
Yeah,
is good. I like
alright.
that.
The eyes.
So yeah, we have the eyes, we have the ears, we have the joints. They're another part, and they're like for proprioception, and the brain integrates all that information together. Now, within the ear, what is the relevant anatomy for balance? And actually, in this case, it'll be vertigo.
I reckon primarily your inner ear and the fluids in the inner ear
Yes.
that kind of help with that balance. I know there's from first year anatomy, the whole fluid balance and how it kind of circulates. I think there's 3 semicircles or something like that.
No, that's better than me. So
Okay.
that's pretty good. So yeah, the inner ear is correct. Now, the inner ear, for the purpose of this, we can like separate it into 2 parts. So there's like the part for hearing, and that's like the cochlea. Forget about that. The inner ear, really the only part that matters is the part for balance. And what's the part of the ear that's for, you mentioned one of them. Yes, the semicircular canals.
Yeah, and a vestibular nerve as well.
Yeah, like the vestibule and the nerve from downstream from it. Yeah. That's going to be the main area of focus for this podcast, is going to be the inner ear, and specifically the vestibule, the semicircular canals, and then the vestibular cochlear nerve that transmits the information to the brain. And the brain as well, because the brain's involved.
Yep.
And as we'll see, the brain can also be
Brain's this magical thing, right?
the brain does so many nice things. What is like vertigo? What do we mean when we're talking about vertigo? If someone presents to you, what are they going to say they have? Are they going to say they have vertigo?
No, they usually say they're dizzy, right?
Yeah,
But dizzy is just very non-specific. So,
Yeah. exactly.
So what kind of questions would you be asking when you're trying to differentiate the types of dizziness?
well, for the purposes of exam, if they're ever going to discuss vertigo, it's always a classic description of like the room spinning around them. But yeah, dizziness can mean a few different things. I don't know.
Does anyone have any ideas of some of the things? If someone's saying they're dizzy, what might they have?
They could just be unsteady on their feet.
Yeah.
And they could be lightheaded.
Are you going to faint? I feel like that might be another kind of category.
Yeah. Yeah, that's good. So those are the 4 that I kind of had down as things that could be considered dizzy. And I guess it's a really important point about this podcast generally, is one of the most important things you can do is define what they mean when they say they're presenting with dizziness.
Yeah.
Because if they really mean lightheadedness, the history, the examination, everything is going to be different.
So what are those 4 categories of dizziness again?
So the 4 categories is vertigo, and you did a good description of it. So it's like this sensation of like movement or spinning. Sometimes people refer to it as like a visual hallucination.
Yep.
The second one is disequilibrium. I think JT touched on that. It's an imbalance, the sense of imbalance due to disturbed sensory input. So that could contain the ear within it and vertigo, but it could also be related to the eyes or joints. Any kind of disruption in them could be a cause of disequilibrium.
Yeah.
And then there's presyncope, so that feeling like you're going to lose consciousness. And then there's lightheadedness, which is more vague. It's just dizziness. It could be due to anxiety, it could be due to panic. So like another symptom you would want to ask about is if they've had any nausea and vomiting, because imagine you're dizzy all the time, then that would make you nauseous. And it kind of gives you a good metric of the severity. So we have someone's come in, we know that they're saying they're dizzy, and now we've been like, what do you mean by dizziness? They're saying, I feel like the room is spinning around me. Now, what are the differentials in your head you're going to have?
Yeah, the most obvious one would be like BPPV.
Or maybe we should just say, what is BPPV?
Benign?
Oh, good.
Paroxysmal.
Very nice.
Positional. Vertigo.
Vertigo.
And the V is vertigo. Very good. So it's benign paroxysmal positional vertigo, or BPPV.
Well, I guess the name actually kind of helps explain it, right? So it's benign, meaning that's not really like life-threatening or anything. Paroxysmal means that it's in short spurts.
I think so. Paroxysmal, I kind of think like sudden.
Yeah,
short
sudden,
bursts
it's short.
and spontaneously.
Yeah. And then the last one, positional, right? So it usually occurs when you're like getting up from bed or sitting upright. It kind of describes when the vertigo occurs.
Yeah, it's a good name that kind of describes the symptoms. Does anyone know how it comes to be, the pathophysiology?
Something with the crystals in the ear, and it's been displaced of some sort.
No, yeah, so it's the crystals in the otolith organs. They dislodge and then they enter the semicircular canals. And when you move your head, when you change position, they can disrupt the normal functioning of your semicircular canals.
So usually you don't have any crystals.
You don't have
but-
loose crystals.
Yeah.
Remember we were talking about the parts of the inner ear? It's got like the parts related to balance.
Yeah.
Was the vestibule and the semicircular canals.
Mhm.
Yes.
The otolith organs are part of the vestibule component.
Yeah.
And we won't go too much into it, but they are perpendicular to one another, the otolith organs and the semicircular canals themselves.
Yeah.
And they have a channel through which they can communicate.
And the crystals fall through.
Yes, and the crystals fall through into the semicircular canals.
Bad boys, get out of there.
Causing vertigo. Nice.
Excellent. What's another one?
Vestibular neuritis.
What would that be?
From my understanding, it's just inflammation of the vestibular nerve. Obviously, the vestibular nerve plays a role in balance. And so if it's inflamed, you're irritating that balance mechanism, yeah. Potentially causing vertigo.
Now, there's something that's often kind of grouped together with vestibular neuritis.
You're talking about labyrinthitis?
I am talking about labyrinthitis.
My understanding is the difference is labyrinthitis, you just have hearing loss. So it is kind of like vestibular neuritis with the addition of that hearing loss.
Yeah, and you can kind of consider them on a spectrum, and they both relate to the vestibular cochlear nerve. So with vestibular neuritis, you have the inflammation of just the vestibular part of the vestibular cochlear nerve. Whereas with labyrinthitis, you get inflammation of the entire vestibular cochlear nerve.
So it's more severe form.
It's a more severe form, and also, as we remember, the cochlea is to do with what?
Hearing.
Yeah.
Oh, that's
That
why you
makes
get
a lot
hearing
more
loss.
sense.
Yeah. All right, what's another differential?
Meniere's disease.
What is Meniere's, JT?
I think this is some sort of inflammation or infection of the inner ear causing some fluid buildup, usually inerty.
It can be inert, it can be idiopathic.
Okay, right.
But it's the endolymph which lines the semicircular canals.
Yeah.
What can happen is there can be a buildup in fluid in there, usually idiopathically. And then this fluid can build up to the point that it ruptures the membrane entirely.
Mm.
And this results in a mix of the endolymph with other surrounding fluids. And it takes time for that to repair. So it will just cause a longer kind of vertigo because you're waiting for the actual endolymph to heal.
Okay. So it gives more prolonged vertigo symptoms.
Yes. So those are the three main ones, I guess, that we can think about. So like BPPV, vestibular neuritis or labyrinthitis, and then Meniere's disease.
Do you have to rule out any other conditions or?
Yes, you can, definitely ruling out. But I guess lead into that is a good way to categorize vertigo.
Yeah.
And does anyone know like how we generally like to think about it?
Talking about like peripheral versus central vertigo.
Yeah. And what would be a peripheral vertigo in terms of what parts of the body would be involved?
It's related to what you told us earlier, with the ear and the eyes are peripheral and the brain is central.
Yes. So in this case, peripheral would be like the inner ear itself and then the nerve supplying.
Mm-hmm.
Yeah.
So the causes we gave, which were the benign positional vertigo, vestibular neuritis, and Meniere's disease, and labyrinthitis. Those are like peripheral causes of vertigo.
Yeah, they would all be peripheral. Now, some central causes are things we haven't mentioned, but what could be a central cause? We're thinking about things that are impacting the brain. What's like an obvious one we want to rule out?
Stroke comes to mind for me for central.
Yeah, definitely. So like a stroke, TIA,
Mm-hmm.
obvious cause impacts the brain, could impact that part of the brain that's involved in balance. What else is there?
Tumors.
Now that would be,
Oh, because it's not in the central. Yeah, it's not in the actual brain.
there's also like things like a vestibular migraine. In my mind, no one knows what a migraine is.
Apparently, some of the theories about migraines is that it could be a spasm of the blood vessels or something.
All right.
But the main thing we want to rule out are those strokes or TIAs,
Yeah.
essentially.
And then also there's one other one. So like MS, multiple sclerosis.
Oh, okay.
Okay.
Yeah. So under peripheral, I should also mention that a thing like an acoustic neuroma, which is, does anyone remember what an acoustic neuroma, like specifically what it is?
Is it a benign tumor near the nerves or
Of the
Neither.
Of the
nerve.
vestibular, yeah, I think
of the
nerve,
vestibular
right?
nerve? Or like, I don't know if it compresses on the
affects
nerve.
hearing, acoustic. Surely it's named for a reason.
Yeah, it definitely does affect hearing.
Hmm.
You get like, if you have like sudden onset sensory neural hearing loss, unilateral sensory neural hearing loss. All right, Alex, summarize. How do we categorize vertigo, and then what are the differentials within each?
Cool. So you've got your central and your peripheral vertigo. Those are your separate categories. For peripheral, you've got BPPV, you've got Meniere's disease, you've got vestibular neuritis or labyrinthitis, depending on the severity, and you've mentioned also acoustic neuroma. For your central causes, you've got stroke, MS,
Oh,
forgot for central,
migraine.
and migraine. Yeah, vestibular migraine. That's right.
Nice.
All right, so now we've got some differentials in our mind. Patients come in, we know they have vertigo. Now we have our differentials. Now we're going to move on to the history. What are some of the questions that we could ask that could help us differentiate between those?
That'll be fancy. Temporal features, right? So like, when did it start? Does it come and go? Those sort of questions.
Very good. And then in line with that, how long? How long has it been going on for?
Mhm.
That's a pretty big one, the duration.
So duration. So thinking of differentials, so usually like a shorter duration, you'd be thinking more like BPPV. And then longer, would you be thinking more of vestibular neuritis?
Didn't he say the Meniere's? Meniere's.
Yes, yep.
That one takes longer time, right?
Yep.
So that's the importance of that temporal question.
So essentially, if they come in and they're saying they have like 30 seconds or so, like less than a minute worth of vertigo, then you're thinking this sounds a lot like BPPV. If they say it's like when they move their head, you're like, done.
So triggers are really important, right?
Yeah, triggers are important.
Actually, I have a question before we kind of move on.
hmm
What's the most common form of vertigo? I know we've got the peripheral and the central, but what's the most common? Would it be BPPV?
I would imagine it's BPPV. It's pretty common.
Yeah, because I feel like that can kind of help lead your questioning as well. If you know like BPPV is the most common,
Yeah.
then you'd ask, okay, like how long for
Mm.
starters, and then maybe is it positional, and then
Yeah.
maybe you're like, okay, if it is positional, then maybe you can start going down that route.
Mm.
Kind of
Yeah.
helps you rule out maybe some of the other causes.
Yeah, definitely. So yeah, we have duration. We have like triggers. So yeah, positional. That's a
Yep.
good one. What are
Mhm.
some other triggers that you might ask about?
Kind of recent ERDI might help in terms of if you're worried about that infective kind of cause.
Yeah, and what differential would that be?
Vestibular neuritis,
Yeah,
primarily.
nice. And on that kind of vein, we're thinking of now you've asked about vestibular neuritis. How do you differentiate between that and labyrinthitis? What other question would you ask?
Yeah, checking for hearing loss as well.
Nice.
Okay. So we got the duration, triggers, recent infections, hearing loss. I guess you want to rule out central cause. So you want to ask about like any stroke-like symptoms. So maybe things like weakness, numbness, paresthesia.
And then more triggers is like, got hit in the ear. It could be a traumatic vertigo. Also, you can kind of think of it as like BPPV, the same thing. If it dislodges, anything that can kind of cause it to dislodge, and that could include trauma.
Yeah.
So we have that. And then another feature of kind of like temporally is like, does it come and go? So is there recurrence?
Mm.
Now, if it was recurrence, what would you be more likely to assume of those differentials?
So my understanding with BPPV is that usually like reoccurs,
Yes.
whereas acute vestibular neuritis is kind of like one episode, which is usually longer.
Yep.
So if they're an ED, like their first presentation could be like acute vestibular neuritis, which has kind of gone on for a few hours and
Mm.
they've come in. Whereas BPPV kind of just reverts back to normal
Yeah.
after the episode.
That's correct. So yeah, BPPV is one of them, or like Meniere's.
Yeah.
And migraines.
Sweet.
So you're kind of thinking about those ones.
There's no real like known cause for Meniere's disease.
I feel like it's mainly idiopathic. I know that.
I also thought it was just idiopathic. That was my
Yeah.
understanding, but
What other history stuff have we missed?
So now, yeah, the good thing is with the stroke things, and that's kind of where you can rule out most of the other kind of possible associated symptoms.
Yeah, because I guess for an OSCE, right, if someone comes with dizziness and we don't ask those central kind of causes,
Yeah.
history questions, we're going to fail.
Yep.
Not being safe. So
Yeah, so definitely asking about like, do you have any vision changes, any neurological deficits?
Is a vestibular migraine the same as a migraine? Like, would I still ask the same aura questions?
Migraines can be pretty diverse. Do you know much about migraines, Alex?
I think obviously you would ask about aura. I feel like you're trying to tie in whether or not a migraine could be causing the vertigo. So I think by asking questions
Oh,
about
right,
aura,
okay,
by asking
yeah.
questions about headache, you're kind of tying it in. Okay, is the migraine the cause of the vertigo? Does that make sense?
That's why it's called a vestibular migraine.
I think so,
Okay,
yeah.
all right.
I
Because
think
some
that's it.
migraines don't cause vertigo.
Yeah, exactly.
Okay,
Yeah,
all right.
yeah.
I'll go
I
to
see.
exam.
Yeah, so that's a good way to kind of think about it, tie it in together. And in terms of past medical history, things that you could ask about, this is a bit more niche, but things that are ototoxic,
The mycins, right? The
the
gentamicins.
mycins.
stuff.
Yeah, very good. Now, kind of as an aside from this, but like actually in practice, even though someone's come in, they've told you that it feels like the room is spinning, you still would want to screen a little bit for kind of pre-syncope because that's a pretty big red flag symptom to miss out on. So asking about those kind of cardiovascular type symptoms,
The
like
palpitations,
Yeah.
chest pain, shortness of breath.
so yeah, definitely asking about them would be useful. So it's pretty much duration and then the triggers. Those are positional. Have you had an ERDI? And then associated symptoms like do you have any hearing loss, any tinnitus? Recently been hit in the head, I guess, would be another trigger. If you really want to indicate that you're looking for Meniere's while you're doing an OSCE, is you're like, do you have any ear fullness? Do you feel like your ear is full? Because that's a
Nice.
sensation. I guess that makes sense in terms of the pathophysiology. If it is to do with the fluid filling up and bursting, that would make sense.
There's some other symptoms in Meniere's as well that you could probably ask about. Is
What
that
are
right?
they? Go ahead.
I think you get tinnitus as well, which is that ringing
Mm.
in your ear.
Mhm.
I think you do get unilateral sensory neural hearing loss as well.
I think you could probably get all of them.
Yeah, I think that's classic
Yeah.
Meniere's, but I got to double check.
If you have on your differentials ear stuff, you pretty much ask the same questions every time. You're like, have you had any balance changes? Do you feel like you have any tinnitus, any hearing loss, any
Any
like,
otorrhea.
fullness in your ear, any stuff leaking out your ear? Just ask a bunch of ear questions and you'll probably narrow it down. After you've done that, you've got a pretty good idea of kind of the history of the vertigo,
Yeah.
possible triggers, and any associated symptoms. Now you're moving on to the exam. Let's say the patient has came in and it sounds like they've had short positional vertigo that comes and goes. And by short, we mean like 30 seconds or so. What's going to be your primary examination?
Do an AT exam, man, because you'll be having a stroke right now.
I'm curious though, because I've listened to the podcast a couple of times and you always say 8 assessment. And I imagine that's because you want to cover your bases, you want to be safe,
Yeah.
right? But obviously in a case like this where it's vertigo, would you...
You definitely don't do an 8
you
assessment,
definitely
by the
wouldn't
way.
do an 8, right?
You're just doing a brief scan,
I
just
get
check
you.
that they're hemodynamically stable
Yeah.
before you move
But
on.
OSCE-wise, I'm curious. Is that something
It's-
that
no,
you guys
No,
get?
it just depends on the cause,
Yeah,
right?
gotcha.
My rationale is that they fail you if you're unsafe.
Yeah.
And a patient who comes in with dizziness
Sure.
theoretically has a risk of having a stroke,
Sure.
TIA,
Several causes, yeah.
some arrhythmias, right? So it once again depends on the history, right? If they're talking in front of you and they look well,
Mm-hmm.
not going to be doing a full AT assessment.
yeah.
But just because dizziness can be caused by a
Yeah,
serious
gotcha.
thing, it's just to
Gotcha.
cover your bases.
Yeah, it's essentially what the things that would matter is be like you would look at his vitals, or you just be like, yeah, you generally look at them. If they
Yeah.
appear well, then you do the normal history. If they appear unwell, you could do an A to E. Yeah, if they appeared really unwell.
I would say then
What I
I'll
would
do
say.
a general observation then.
Cool. Yeah.
Yeah.
Do they look well, unwell? Are they slurring their speech, whatever? Things like that. JT, what would you do next?
I'll get their vital signs and just to make sure that they're hemodynamically stable. But because this episode is focused on BPPV, so I'm going to target the examination with the Dix-Hallpike maneuver to assess if they have BPPV.
Nice.
Would you do an ENT exam as well?
Yeah, you do an ENT exam. Have a look in there. So BPPV, Dix-Hallpike will be your primary, but you still do all the other jazz.
So
So
can you explain a Dix-Hallpike?
fuck no.
That's
but
a real question.
the change of position is the thing that unlodged the crystal and caused it to be in the wrong place. The Dix-Hallpike essentially gets them to do a bunch of maneuvers that would dislodges it again and elicits that vertigo experience.
Okay.
And if you did see that, you could just progress on to the Epleys within the same kind of set of maneuvers.
So essentially trying to
relodge.
trigger their BPPV
Mm.
symptoms with the Dix-Hallpike.
And I think a way you can also see that they can describe they feel vertigo. And I think you can also, if they have nystagmus, I think that's another.
I think you are looking for nystagmus with the Dix Hallpike as well. Yeah.
Yeah.
So are they dizzy in that position that you put them in?
Mm.
And do you see nystagmus?
Yeah. Nice.
Yeah.
So that's that. That's the main examination for that. And then looking at the ear. So you're looking at the ear. What
Yeah.
else would you do? What other examination stuff?
The hints exam.
Yep. So the hints assessment, the main one that we kind of think about for this is like the head impulse test, which is the H and the I. And the purpose of it is to distinguish between central and peripheral causes of vertigo.
I've been told, though, as my gen med consultant said, that you should only do it in people that you suspect of a central cause.
Yeah.
And so you can't use it to rule out a peripheral to central
Yeah.
cause.
Mm.
But most people do it anyways, which means that the results of that test is kind of screwed because you're not using it in the right context.
Mm.
Do you know why like it might not be so useful?
You get like
And
false
someone with, like,
positives or false negatives. And
Yeah. It's kind of on that. And it's also to do with like the findings. So let's say you had a normal person, you do a head impulse test on them, and then you have their normal response. But then you have one patient with peripheral vertigo and one patient with central vertigo. The patient with central vertigo would have a normal response to the head impulse test.
Yeah.
And then the person with peripheral vertigo would have abnormal response. So it's kind of reassuring in a way.
So with the hints exam, you only do it when you suspect a central cause.
Mm. So other hearing things, what are some ear things? So you want to do hearing tests. So your Renes and your Webers, just kind of assess the ear more broadly. You mentioned looking in the ear. What's that called?
An otoscope. Or...
Yeah, very nice. What other kind of maybe balance type tests would be pretty good?
I just think of like a generalized gait to
Yep,
kind of
gait's
start
one.
off.
Oh, what is it? The Romberg
Your
test?
Rombergs,
Romberg.
yeah, get them to close their eyes.
Yeah. And then you do just general things, again, for the pre-syncope. That would just be covered in your vitals. So you do general observation, you do your vitals, you do a bunch of these specific tests, and then you want to rule out pre-syncope if you still haven't got a confirmed diagnosis. So you do like check their pulse, maybe do an ECG, pretty standard stuff.
Was that all with the balance? Just the gait?
Yeah, it was like gait and Romberg test.
Oh, that's it.
Okay.
Yeah.
So
Sure you could do
if I'm in
more.
an OSCE, I'm going to be like Brusker. Going to do a general observation.
Mm,
Then going to assess their vitals.
yeah.
I'm then going to do an ENT exam and a Dix Hallpike.
Mm,
I would consider doing a hints examination if I think a central cause is highly suspicious. And I'd also do a gait assessment and Romberg's test to assess their balance.
mm-hmm.
And maybe do some targeted exams of the respiratory or cardiovascular if I consider like a cardiac cause.
When I think of like the head impulse test, I think of it being appropriate if someone's had like long vertigo. Because then you're kind of
Yeah.
thinking, is this vestibular neuritis or is this like a stroke or something to that effect? More so than if you're concerned about just a central cause.
So in general, like if the patient, you think it's likely BPPV, what general investigations would you do? Like what bedside?
If it's BPPV, I wouldn't order any investigations.
Okay. Let's say you're less suspicious for BPPV and you're thinking one of the central causes may be more likely. Like what investigations would you do then?
So let's say it's like not a stroke, because a stroke is like a different thing. Let's think about they've just had this vertigo.
Yeah.
I think in those cases, you would order audiology assessment.
Yeah.
To see if they have any hearing loss, and then you do the head scans. And in these patients, an MRI would be the gold standard because it's like soft tissue stuff. And if you are going to do a CT, you do a CT with contrast. So
Okay.
that would be different to obviously a stroke.
Okay. So essentially, if you're thinking a central cause could be possible, you want to rule it out with some sort of brain imaging. And you can always consider doing a proper audiogram to assess the hearing.
It could be, yeah, central or peripheral, like a Meniere's or an acoustic neuroma. You'd also want to do those things. If it's not BPPV,
Yeah.
and it doesn't really look so much like it's vestibular neuritis even, then you're concerned about the other common differentials like Meniere's, a migraine, or an acoustic neuroma, or like some other
Yeah.
brain pathology. And those are the situations which would be obvious to you. You'd be like, this isn't BPPV.
Okay. So if it's not obvious it's BPPV or like a vestibular neuritis, you're going to be strongly considering a CT scan or MRI of the head.
Yeah, you would be like, I want to send them off to do audiology, confirm this is sensory neural hearing loss, which it would be in both the case of a Meniere's or an acoustic neuroma, I believe.
Mm.
Yeah.
And following that audiology assessment, you would be pretty concerned about what the differentials are. So then you would do head imaging, and it would be MRI is the gold standard.
Yeah.
For all of them except for BPPV, really, because BPPV is quite short. What do you think people with dizziness could benefit from generally? Let's say they've got like a lot of dizziness.
I feel like it depends on their symptoms.
What might be a symptom that they would have?
I feel like you definitely can get nauseous
Very
and
good.
vomit with vertigo. Obviously, the room's spinning, you don't feel great. In that case, antiemetics would definitely be a really good option for management for those type of patients.
Antiemetics, that's correct. That's pretty much the main thing. So any of the patients, if they've got kind of a longer standing vertigo,
Yeah.
give them antiemetics. You wouldn't really do it with BPPV.
What antiemetic would you add?
Chlorchlorperazine is a good one for antiemetics and vestibular stuff. The other thing that all the patients can get is like vestibular rehabilitation with the physiotherapist.
You were touching on acute labyrinthitis, vestibular neuritis.
Yes.
You said the pathology is infection or inflammation of the canal.
It is. Yeah, it's like an inflammation.
So you want to use an anti-inflammatory of some sort?
Yep. What would be like a kind of a good,
A non-steroidal
I'd
anti-inflammatory,
assume, yeah.
I'm imagining.
I suppose you could give them a non-steroidal, but a prednisolone, just a steroid.
Oh.
Just give them a steroid.
So vestibular neuritis steroids.
Yeah.
Right.
Yeah.
Okay.
And then for vestibular migraine, now this is a bit niche. This is kind of just migraine management. Does anyone know what drugs we can give to people with migraines are?
Stemetil? I think it's prochlorperazine.
Yeah, it's pro.
Okay, well, that would be
think,
like
yeah.
the antiemetic.
Oh, okay.
That is the antiemetic you would want to give for
Sure.
all of these patients
Right,
for
right.
symptomatic management.
Stimatal.
And then just migraine stuff. It's those MISC drugs that just do a few things. So it's like amitriptyline. You just say amitriptyline.
So
And maybe like a
amitriptyline's
propranolol or something. There are 2 drugs that could help with migraines.
Yep.
And then if they come in, you think it's acoustic neuroma, what's the management?
ENT referral.
Hell yeah, dude. Yeah, ENT referral, so they can like surgically remove it or give it some radiotherapy.
One of you guys want to summarize and just include BPPV as well?
All right. So the management of all these peripheral causes of vertigo, we can give them antiemetics. And the most common one used is prochlorperazine, which is also known as Stemetil. For BPVV, you can do the Epley maneuver as a management. For the inflammatory causes of peripheral vertigo, such as acute labyrinthitis and vestibular neuritis, you can give them prednisolone, a steroid. And then for the acoustic neuroma, you just refer to ENT to get them to sort it out. And then for vestibular migraine, you can consider giving them propranolol or amitriptyline.
I guess this is like an interesting clinical point is sometimes a patient can have a single insult of vertigo and this can disrupt the vestibular signaling system
Yeah.
and cause balance issues. Kind of this would be like a disequilibrium type thing. So it might be important to further clarify that since the initial time that they got it, have they been having the same type of dizziness as that initial instance? Because that could just be like the follow-up disequilibrium type stuff as opposed to vertigo itself.
I just realized even with management as well, right? If someone's suffering from any of these vertigos, I think we have to educate them at like how to get up from bed so they don't have a fall and smack their head. And then you probably have to safety net them as well.
Yeah, no, yeah. I mean, I guess if they have like kind of a longer standing vertigo, like a Meniere's or something that lasts longer, that would have implications for like their commercial or personal driver's license.
Yeah.
So there are 3 key takeaways from this podcast. The first being when a patient comes in and they say they're dizzy, you want to confirm that that dizziness is in fact vertigo. So asking them, is it a sense that the room is moving around you? Confirming that it's vertigo allows you to kind of go on to the rest of the vertigo questions and not wasting your time too much on those lightheadedness, pre-syncopal causes. The second point is that BPPV is a common cause of short, so like 30-second vertigo. Meniere's is a common cause in like extended vertigo, so like if it's hours or days. And vestibular neuritis is a common cause of even more extended vertigo, so for days to weeks. And it can be preceded by a viral infection. And the third point is the management depends on the specific condition. So in the case of BPPV, it's pretty straightforward. You've done the Dix hole pie, confirmed it, then you've done an Epley's maneuver. If it was one of the other causes, things you can always offer them is vestibular rehabilitation with a physio, and then symptomatic management with antiemetics, as well as whatever specific management for that disorder. And that's it.
Thank you for going
Is that
through
it?
Vertigo today, Brosca. Thank you for coming, Alex.
My pleasure. Thank
it's
you for
great to
having
have a new
me.
guest on. And JT, as always,
Thanks.
catch you for the next episode of 1 p.m.
We'll see you next time.
Thank you.
We're really excited to be collaborating with Becky from Becky's Notes. Becky's Notes bring together all the key topics medical students need to know in a readily available place, reviewed by specialists in the field. These visually striking notes are a refreshing change from all these boring textbooks out there. You can check her out on Instagram at Becky's Notes 01 and support her at the links below.